Morning, everyone. 25 years has passed since the first HEADS trial study results were published, and yet HSV keratitis remains an enigma to ophthalmologists across the world. We often see and are entangled in a web of complex case scenarios of HSV keratitis that we need to come out of. Unaware of what could be a simplified management approach to these cases, we often land up in a hot mess of repeated recurrences and ever unhappy patients. So today, I, Dr. Vikas Veerwal, welcome you all to this instruction course on HSV keratitis. Along with me are my esteemed colleagues, Dr. Akansha Kaul, Dr. Niket Gandhi, and Dr. Abhishek Dave, as well as Dr. Anahita Kate, who would take you through some very simple answers to all the queries that HSV keratitis poses to us. We will try to simplify the approach in diagnosing and managing these cases and give you practical tips that you can take to your clinics and utilize them. So let's get started straight away. And first and most importantly, I will call Dr. Akansha Kaul to present and simplify the HEADS trial studies for everyone here. She would try to give the points that most people actually miss when they read those trials and what we need to actually extract from these trials when we apply and take these trials to the clinic. Dr. Akansha Kaul.
Very good morning, everyone, and thank you, Dr. Vikas. So to begin the IC today, we are just going to delve a little into history because history remains the most important in any future progression that we may have. So this was a landmark trial. The herpetic eye disease study has given us so much to learn and about the management, though after that we will also be discussing what more needs to be added and how this study needs to be evaluated. So to begin with, what was the need of having a HEADS trial? Why was a study done with so many clinical trials on a single topic? Because HSV is an endemic disease throughout the world, and there have always been controversies about when the steroids should be started, at what frequency they should be started, in what type of HSV should we start steroids, and what is the role of giving oral systemic therapy? Is it indicated in all patients? How long do you want to give it? So the controversies don't end in this topic. So I'm trying to just give us the gist of what these studies taught us. I'll go one by one at each clinical trial. So the herpetic eye disease study 1 basically had 3 clinical trials. I will try to bring it down to the basics so that we all make it easy and we get to know what these trials were trying to tell us in the end. So now the first clinical trial was to study the efficacy of adding topical steroid eye drops in a patient who had HSV stromal keratitis and was being already treated with a topical antiviral. To make it simpler, let's look at this patient. Patient of HSV stromal keratitis, he is being treated with topical antivirals for the past 10 days. Now, would you want to add topical steroids or not? Is there any role of adding the steroids? So what they did in this clinical trial is they divided it into 2 groups. One group did receive the topical steroids, which was tapered over 10 weeks, and the other received a placebo drop in the same frequency. And what did they find? So they were trying to see that how many patients failed the treatment. By failure, they defined failure as any worsening in the inflammation or any adverse effect or no change in the inflammation. That is, the patient did not respond to the treatment. And what they found that there was a significant benefit of adding topical steroids in this group. Therefore, what can we learn from this? That yes, addition of topical steroids in the stromal keratitis patients does lead to faster resolution of the disease and lower percentage of treatment failure. Now, from the failure, they also studied what were the patients who succeeded in the treatment. That means their keratitis resolved. So between the 2 groups, there was no significant difference, though the number was higher in the steroid group, but statistically they did not find a significant difference. Now from this trial, there are some important considerations that we need to note. Were 10 weeks of tapered corticosteroids enough, or was it too brief? Because when we go into the details of the study, we realize that the patients who failed the treatment did so in the 6 weeks of observation period. That is when the steroids were discontinued. So should we taper our therapy more slowly for these patients, or should steroids be given for longer? So my other speakers will be taking up the topics ahead from the head study. Now another outcome they were looking at was the visual outcome. In the end, what they suggested was that immediate corticosteroid treatment is not required for better visual outcome. This means that in the patient, if you delay starting the topical steroids by 10 days or 15 days, it does not affect the final visual outcome at the 6 months or at 16 weeks. So yes, corticosteroids are needed, but it's not necessary to start them right at the beginning of your treatment. So now we are coming to the second clinical trial of HEADS 1, where they wanted to study the efficacy of adding oral acyclovir in a patient who was already receiving corticosteroids as well as antivirals topically. So now this patient, imagine that the patient is on antivirals and topical steroids for stromal keratitis. Would there be a role of adding oral acyclovir 5 times for 10 weeks? So they divided again into 2 groups, one receiving a placebo and one receiving oral acyclovir. And they found that there was no difference. There was no use of adding the oral acyclovir over the topical acyclovir, and the failure rates remained similar over 10 weeks as well as 16 weeks. The stromal keratitis resolution was also equal between the 2 groups, and therefore they said that if the patient is already on topical antivirals, there is no difference if you add oral acyclovir in the terms of time to resolution and the number of resolved cases. Now in the third clinical trial, these were patients of herpes simplex iridocyclitis who were receiving topical steroids. They were divided into 2 groups, one received oral acyclovir, one received placebo, and they saw that the failure rate was higher in the placebo group. And therefore, oral acyclovir may be indicated in patients of iridocyclitis. However, the sample size was small, so the statistical significance is still questionable. Now, from herpetic eye disease study 1, we move to study 2, which again had 3 clinical trials. Now, in the first one, imagine a patient has HSV epithelial keratitis. Is it necessary to start the patient on oral acyclovir to prevent progression of the patient developing more blinding complications like stromal keratitis or iridocyclitis? So the patient is already being treated on topical antivirals. They put them in 2 groups. One group received oral acyclovir, the other group received a placebo. What they saw was with the topical antivirals, most of the patients of HSV epithelial keratitis, 99% of them were anyway resolving by the week 3 visit. And stromal keratitis or iritis developed in similar percentage of patients between the 2 groups. But patients who had a history of stromal keratitis earlier, most of them developed stromal keratitis later as well. So what we learn here is that there is no benefit of adding oral acyclovir in preventing a patient of epithelial keratitis to develop stromal keratitis in the future. However, if the patient has had stromal keratitis, yes, there is a higher risk of this patient going to develop another episode of stromal keratitis in the future. Now, another clinical scenario, the next clinical trial is that the patient has resolved HSV stromal keratitis. For the previous 1 year has had no episode. Suppose that is the case. Would you now add oral acyclovir in preventing recurrence in a prophylactic dose? So I'll just try to wind up. So the addition of oral acyclovir in a prophylactic dose did reduce the incidence of recurrent disease, and this reduced the incidence by 50% that the patient will have a recurrent episode. So yes, prophylaxis does work in the patients of stromal keratitis. Okay, so now what is important here is that once the oral acyclovir was stopped, this difference, this benefit that the prophylactic group was getting was lost. That means once the acyclovir is stopped, then you cannot expect the patient to still not have any recurrence because the patient was on oral acyclovir for some time. So with time, once the acyclovir stops, the beneficial effect is lost. But the oral acyclovir does also prevent recurrence of non-ocular disease or the patient having a non-ocular episode of HSV. Now, this was the last clinical trial of HEDS2 where they just evaluated the effect of any psychological environmental factors, and they found that there was no other external factor that can lead to recurrence in these patients. So, this is a concluding slide where I'm going to try to give you all the key points from HEDS1 as well as HEDS2 after this multiple clinical trials that we've gone through. So, what they suggested was for epithelial herpetic keratitis, there is no role of any prophylactic use of oral acyclovir. In stromal herpetic keratitis, there was a role of prophylaxis which reduced the recurrence by 50%. To manage stromal herpetic keratitis, addition of tapering corticosteroids is needed with the topical antivirals, but there is no additional benefit of using oral antivirals in case the patient is already on topical antivirals. But this was a delve into history. Now, when we are taking this to clinic, we need to take it with a pinch of salt, keeping in mind that we have availability of newer topical antivirals, oral as well as topical antivirals. Newer agents are available which were not included in this study. These studies did not give us what was the role of reactivation of disease if the patient had an excimer laser or had a cross-linking procedure. Of course, we have to look at our area and consider the socio-economic consideration of keeping the patient on prophylaxis for acyclovir for how long. What is the treatment cost for him to be on long-term prophylaxis or on a treatment if he gets an active episode? So there are socio-economic considerations and a physician preference where we may not be comfortable in just keeping the patient on topical antivirals if the patient is having a stromal keratitis. So some physicians do prefer to add or keep the patient on oral acyclovir. So these are some questions that my next speakers will be taking up, and then we'll have a better, clearer picture of how we can add on to the HEDS trial. Thank you.
Thank you, Dr. Akansha, for summing up HEDS trial for us so well. Next, we have Dr. Abhishek Dave, who would be giving some pearls on management and diagnosis of HSV epithelial keratitis.
Yeah, so good morning everyone, and coming to the first clinical presentation of HSV, so I'll be talking about HSV epithelial keratitis. So HSV epithelial keratitis can be classified basically into two types, the infectious epithelial keratitis and the neurotrophic keratopathy. And infectious further can be classified into corneal vesicles, dendritic ulcers, geographical ulcers and marginal ulcers. So we will be discussing them one by one. Symptoms and signs, coming to the symptoms, they are basically same as for any corneal ulcer. So there will be photophobia, there will be pain, epiphora and decreased vision. The earliest lesion is small raised vesicles on the epithelium and they stain negatively initially, and later they coalesce to form the typical dendritic ulcer. So coming to the main presentation of HSV epithelial keratitis, so this is the typical dendritic ulcer, which comes from a Greek word dendron meaning tree. So as with the tree, there are branching linear lesions with terminal bulbs. So these terminal bulbs are very important to note because they would be helpful in differentiating them from the other pseudodendrites. The swollen border of these lesions have the live virus. So this is one of the HSV condition where a live virus is present on the eye. Coming to the staining pattern of a dendrite, so they stain positively with fluorescein stains. So if you see the base of the ulcer, that will be staining darkly green with the fluorescein. The epithelial borders stain negatively, though the epithelial borders, if you stain, would stain with the rose Bengal dye. So this is also known as double staining, where the borders stain with the rose Bengal dye and the base stains with the fluorescein dye. So how do we differentiate dendrite from other non-HSV causes of pseudodendrites? So this is one example of HZO or herpes zoster pseudodendrites, where we see the dendrites are very shallow, they are very thin, and there are no terminal bulbs. So that is an important thing. Other conditions which can lead to a dendritiform lesions could be toxic medicamentosa, so where a lot of medications can cause an ocular surface irregularity. Also, at times, epithelial defects, when they are healing, can give the shape of a dendrite. So the next presentation can be a geographical ulcer. So if a dendrite is left for a long time untreated, or if it's treated wrongly with steroid, then it can lead to a geographical ulcer. So basically these are enlarged non-linear dendrite. So if you see, this area has become much more thickened than a typical dendrite, and these are still dendritiform. Important to note are these scalloped edges which would be there. Coming to the marginal ulcer, so these are basically epithelial ulcers with stromal infiltration. So there's an intense limbal injection, and these patients are also more symptomatic than dendritic keratitis, and they ultimately progress centrally as dendrites. What can differentiate it from a staphylococcal marginal keratitis is that there is no lucid interval, they are bang on the limbus, and also they can be on other positions apart from the routine 2 and 7 position. So an epithelial keratitis can lead to dendritic epitheliopathy, which are basically non-ulcerated healing dendrite. It can lead to stromal scarring and ghost figure. And important to note is that almost 1/4 of patients can land into a infectious or immune stromal keratitis as the epithelial keratitis is going away. Another presentation of HSV can be a neurotrophic keratopathy, which is basically due to impaired corneal innervation and decreased tear secretions. There is an irregular epithelium and an oval epithelium defect with a smooth thickened border. So here you have to note that the borders are smooth and thickened as compared to a geographical ulcer where they were more scalloped. Coming to the treatment of these conditions, so the mainstay of treatment of a dendritic or a geographical ulcer is topical antiviral agents, as Dr. Akanksha also mentioned, and that is mainly based on acyclovir 3% ointment or ganciclovir 0.15% gel. They typically bind to the DNA polymerase and act like a chain terminator. Ganciclovir though is better tolerated with similar healing rates, but we still prefer acyclovir as the first line drug. And the aim of treatment here is to get rid of the infectious live virus. So typical topical therapy for a patient would consist of ointment acyclovir 3% 5 times a day, topical cycloplegics to prevent the ciliary spasm and pain, broad spectrum antibiotics only add if there is a large geographical ulcer, otherwise for routine dendritic ulcer you do not need any antibiotics, and lubricating eye drops again if the patient is very symptomatic you can add, but has no definite role. Also, one thing to mention is that people have treated dendritic keratitis also with only oral acyclovir 400 mg 5 times a day. That can be done, and the healing rates are exactly the same as topical therapy. Only concern would be the systemic issues and the cost concern, otherwise healing rates are same. So where we would like to treat a patient with oral acyclovir for a dendrite would be compromised ocular surface, patients who are intolerant to topical acyclovir, and it can also be supplemented in cases like one-eyed patients or precious grafts. There one can consider supplementing oral therapy as well. Duration of treatment usually would be the loading dose 5 times a day should be for 5 to 7 days, and once the epithelium starts healing you can reduce it to 3 times a day for another week or so. Longer periods may be needed for a geographical ulcer. So this is the patient with geographical ulcer. Acyclovir ointment was started, the epithelium started healing at about 1 week's time. This is the picture, and at 3 weeks time the epithelium has completely healed up. So what happens if a dendrite is not healing? It can be an incorrect diagnosis, so you have to reconsider the diagnosis. It can be drug resistance, which is very rare in less than 5 to 10% cases, but if this is the case then you can observe, because dendrites may be self-healing also, or you can change to oral agents like foscarnet, famciclovir, or it can be an HSV dendritic epitheliopathy, which is basically a healing ulcer, so you just have to reduce your antivirals to reduce the toxicity. So topical corticosteroids are absolutely contraindicated for an active dendritic keratitis. So once you have started topical antivirals, and if you feel the patient is now going into stromal keratitis, there's stromal infiltration, like in this patient post PK, there is a lot of stromal keratitis developing with the dendrite healing. There you can add low dose topical steroid like fluoromethalon 3 to 4 times a day. Coming to neurotrophic keratopathy, so the basic treatment here is to stop the topical antivirals, add preservative free lubricants 1 to 2 hourly, and a temporary tarsorrhaphy works wonder in such cases. Like this patient with PED post HSV keratitis, a tarsorrhaphy led to the healing of this defect, which was not healing for over a month on medical therapy. And a patient with neurotrophic ulcer, again the epithelial defect healed about in 20 to 25 days here. What about prophylaxis? So Dr. Akanksha has mentioned that as such oral acyclovir is not needed, but if the there's a frequent recurrence of epithelial keratitis, then you can add 400 milligram acyclovir 2 times a day, probably for the lifelong period, because the effect goes away once you stop the acyclovir. So, thank you so much.
So I just had one question for the panelists also, that in some of these cases we do see certain scars in the visual axis post-epithelial keratitis. So what do you recommend starting topical steroids then, and is it something that a general ophthalmologist should do on its own? Because they have to be sure that there's no presence of a live virus then.
So if there is no epithelial defect that you are seeing when the healing has completely taken place, and there is a slight infiltration in the anterior stroma, we often see these types of cases. In that scenario, low potency steroids first of all are needed. You don't need prednisolone acetate because it's very superficial, and the penetration of low potency steroids would also be sufficient. But the important thing is to keep the patient on antiviral prophylaxis when you have kept the patient on steroids. So even if the epithelial lesion has healed, the antivirals need to continue if you are adding a steroid. So that would be.
And just for scars, probably one should not start. But as Dr. Vikas mentioned, if there's stromal infiltration, then yes, it does reduce the scarring.
Thank you, Dr. Dave, for simplifying HSV epithelial keratitis for us. So now I, Dr. Vikas Veerwal, will present on HSV stromal keratitis and how we can minimize the complications and recurrences that happen with it. So I have no financial interests in this presentation. So what makes HSV stromal keratitis such a challenging disease to treat? Number one, it is a great mimicker of infection. So the diagnosis itself is challenging many times. Secondly, we are not sure whether to start on oral Acevir or on topical Acevir, especially in the initial period when we are treating with steroids. Thirdly, we don't know or accurately know when to taper and how to taper the steroids and for how long to continue these patients on steroids. How long to treat these patients with acyclovir prophylaxis as well as with steroids, how long that treatment needs to continue, and what to do when the patient keeps coming back to you with repeated recurrences. So I'll be trying to simplify and answer some of these queries today. So a typical patient of immune stromal keratitis presents with recent onset decrease of vision with mild pain and mild congestion. There is presence of stromal inflammation and infiltration along with cellularity. There can be mild edema, and sometimes these patients may even have few KPs present underlying the area of the inflammation. So to make your diagnosis easier, what you should do is, first of all, you should look for clues that support your diagnosis. So you should ask the patient if the patient has had any history of recurrent episodes, has similar episodes occurred previously. You should look for footprint scars that would indicate any previous episode that has happened. And you should look for vascularization or any ghost vessels that may be present, and best to look after dilating in a retroillumination examination. Corneal sensation may or may not be reduced and is not a very specific sign. So even though textbooks always say look for corneal sensation, but we don't usually take that as a very good indicator to detect whether the patient has had HSV or not. So let's take an example of this 35-year-old female who presented with decrease of vision. She was already on prophylactic dose of acyclovir, but presented with an episode of infiltration and a recurrence of stromal keratitis. Now the question arises in the clinic, do I add topical Acevir or step up the oral Acevir which the patient is already on? Steroids, what frequencies to start and how to taper the dosage of steroids? And thirdly, this patient had recurrence when the patient was already on acyclovir prophylaxis, so what needs to be done for that? So first of all, considering oral antivirals versus topical therapy in immune stromal keratitis. So you have to understand in immune stromal keratitis, it's not an active infection. So the role of acyclovir is only as a prophylactic dose to avoid epithelial keratitis from developing. So in that scenario, oral Acevir is equally efficacious as topical. Now, we can either keep the patient on oral or topical. We don't need to have a dual therapy, first of all. Secondly, if the patient is already on prophylaxis, my preference is to just step up the dose of oral acyclovir rather than adding topical, especially if the patient is already having symptoms related to the surface. But topical acyclovir itself would equally be good enough. But the 5-time dosage needs to be continued till your frequency of steroids is more than 4 times a day. So 5 times, whether oral or topical acyclovir, needs to continue till your steroids reaches 4 or lesser times of frequency in a day, and then shift it to 2 times per day. Now, as Dr. Abhishek told you, that prefer oral acyclovir when the patient has had previous ocular surface issues or is on multiple anti-glaucoma medications. Now, as Dr. Kancha mentioned, the time to initiation of therapy of steroids does not affect the final outcome of the patient, and this is important to know if you are not sure of your diagnosis. Secondly, recurrence of disease happened in 50% of patients within 6 weeks of stopping the steroid. So you stop the steroid after 10 weeks and the patient comes back to you after 2-3 weeks with a recurrence again. So it means that the therapy for 10 weeks is too short and it needs to be tapered much more slowly. And the lower the dosing becomes, the longer should be the tapering period. So let's see how practically I treat my patients of HSV stromal keratitis. I would have started this patient on 8 to 10 times of prednisolone acetate per day and tapered weekly till the dosing is 4 times per day. At this time, my oral or topical acyclovir would be 5 times per day during this period. When the dosage reaches less than 4 weeks, so it becomes 3 times per day and I'll continue it for 2 weeks. When it becomes 2 times per day, I'll make it 3 weeks for 2 times. Then when it becomes 1 time per day, I'll continue it for 4 weeks and then even shift the patient to twice a week or alternate day dosage for a longer period, because I know that the side effects of steroids at such low dosage will be much lesser than the recurrence episode. In this period, my oral acyclovir will continue with the BD dosage of prophylaxis for the patient. Now, the patient presents with recurrences. So, how long to continue on maintenance, and the disease is still recurring on acyclovir. So, what to do about that? So, you have to understand that recurrence is a part of HSV. Acyclovir can only prevent or reduce the recurrence, but breakthrough infections are common even with the prophylaxis. So you have to judge whether this patient is having repeated recurrences or is it just the normal recurrences that you can expect that the rate is not that high. So any form of HSV, 41% is reduced with the prophylactic acyclovir dose. But stromal keratitis is reduced around 50% with prophylaxis. And the more the number of previous episodes, the higher the chances of recurrence happening, as well as the shorter the interval between the recurrences. So that is important. And as previous speakers have emphasized, only affect till the antivirals are continued. While acyclovir OD is equally efficacious as acyclovir BD and can be used in patients who don't want higher frequency of dosage. So what you might be doing wrong if recurrences are happening repeatedly? Are you tapering the steroids too fast? Ask yourself in the clinic. And maintain these patients on low dose steroids for a longer period if you feel that you are tapering it faster than you should. Is the acyclovir 400 mg BD dosage actually insufficient for this patient? Now, acyclovir prophylaxis, if given in higher dosage, can have enhanced effect, as has been seen in some studies in HSV keratitis as well as in genital herpes studies, where it was shown that patients who were on higher dosage of acyclovir actually had lower recurrence rates. So patients can be shifted to 400 mg 3 times a day or 800 mg BD dosage if the patient is having repeated recurrences even with 400 mg BD dosage. And it can also be a rare case of acyclovir resistant strain where famciclovir will also not work and you have to shift to alternate antivirals like cidofovir or foscarnet. Now, so 3 mistakes to avoid in the clinic for HSV immune stromal keratitis. Do not rush to start topical steroids until you are sure about your diagnosis. Do not rush to taper the steroids. So slow taper is the key in avoiding recurrences. And do not stop oral acyclovir prophylaxis too soon for the patient. So to conclude, knowing the interplay of steroids and antivirals is the key in stromal keratitis patients. Slow tapering of steroids and higher maintenance dose of acyclovir if the patient is having repeated recurrences. And the most important aspect in dealing with a patient of HSV is to talk to the patient, explain the nature of disease, and that this patient needs to continue on treatment for a much, much longer period. More often than not in your clinic, you will find that patient come with recurrences because they stopped Asavir and they did not know the importance of continuing it for a long period. Thank you.
So excellent presentation, Dr. Vikas. In few of the cases, we see that the breakthrough infections are sometimes far too frequent. And as you mentioned that the 3-time dosage is something which we can look upon, can consider in these patients. So, I mean, how many percentage of your patients, just a rough number, do need actually a 3-time dosage?
So, very few actually, because more often than not, I find that the patients who are coming with repeated recurrences and are actually on prophylaxis are the ones where the steroids have been tapered too fast. Either the patient has stopped the steroids on their own, or the treating physician has tapered them in a regular manner, how we do in uveitis. So that is where we lack, that we taper the steroids too fast because we feel that the episode has healed, so why continue on the patient on steroids for longer?
And also, when the frequency of steroids is almost alternate day or once the low potent steroids, how frequently would you like to see these patients in your clinical practice?
Once in 2 months or something like that. Okay. So not very frequently.
And one of the few side effects we are concerned because of oral ACV is the systemic side effects. Yeah. So how frequently would you recommend the patient undergo certain systemic investigations, and what type of investigation would you suggest to them?
Renal function tests are recommended by studies to be done every 3 months, but in our clinical practice we usually get them from 4 to 6 months. Right. But 3 months is the ideal time when renal function tests need to be repeated in these patients. That's what has been recommended.
And again, are there any patients because of which you had to stop it, the oral ACV?
Only once or twice, very, very rarely. Right. Yes, we can continue oral acyclovir even lifelong. So we have had patients who have been on lifelong acyclovir, precious graft, or one-eyed patients, bilateral disease. We have kept them for very, very long time. And acyclovir is overall a very, very safe drug. But just to be cautious, because it becomes a medico-legal issue as well, that you need to get renal function tests every 4 to 6 months probably, and the patient understands that it doesn't cost that much to the patient. So the patient, if these patients who are one-eyed, post-graft, or bilateral disease, repeated recurrences they have had, they understand the importance of getting these tests and continuing the acyclovir prophylaxis very long. And most important is for us to explain to them that why they need to do this. It's like hypertension and diabetes, that lifelong you have to be on medication even if you don't have any symptoms. So that's what the patient needs to understand from our perspective. Dr. Anahita, please continue with your presentation.
Thank you. So good morning everyone. Today I'll be taking you through HSV necrotizing keratitis. So over the next few minutes, I'll be discussing when do we suspect HSV necrotizing keratitis, how do we establish the diagnosis, and what are the principles of management. So, of all the HSV keratitis, necrotizing keratitis is probably the one that very closely mimics routine microbial keratitis. And because the normal HSV tests are not a part of our routine microbiological armamentarium, these infections, they get missed, and they are often misdiagnosed and usually treated as fungal keratitis. So it is very important to have a high degree of clinical suspicion. And in which cases do we suspect that, okay, this patient may have an underlying HSV disease? So the first is when the patient gives a chronic history. The patient says that I've had multiple episodes on and off over the past 5 to 7 years, something like that. And also when the patient has clinical signs which suggest that the patient has a chronic history, like the presence of footprint scars, underlying vascularization. Again, this vascularization, when it is deep, it is more suggestive of HSV keratitis. And last but not the least, like you can see in this case over here, when the patient has atrophic iris patches. Now, in isolation, none of these signs are pathognomonic of HSV keratitis, but when they are present together, this constellation suggests that the patient may have an underlying HSV infection. And in these cases, we can either start the topic or start the medications or send the patient for the required investigations. Another point that I would like to highlight here is that the color of the infiltrate. Now, this is the same patient, or the image on the left, the patient has an episode of HSV keratitis, while the image on the right is 1 year later when the patient had a superadded bacterial infection. So we can see the difference in the color of the infiltrate. The HSV infiltrate is more grayish white, whereas the bacterial infiltrate tends to be more yellow in color. So how do we treat these cases? We start with a therapeutic dose of oral acyclovir. This is one scenario where we will not prefer topical acyclovir. All these patients must receive oral. 400 milligrams 5 times per day is the dose of choice. This is usually given in conjunction with antibiotics because whatever tests we give, they take time and they may not always be positive. So we have to treat in line with either with empirical antibiotics or with whatever comes on the smear. And we have to monitor the healing of the epithelial defect and the size of the infiltrate. And when the subsequent cultures also come negative, that is when we can add topical steroids. Now, unlike immune stromal keratitis, where you will start with a steroid dose of 8 to 10 times a day, in necrotizing keratitis, the starting of steroids is relatively slow. So we will start at around 3 to 4 times a day, and we will very closely follow up the patient. So the patient has to be called maybe within 48 hours to 3 days. And here again, counseling is very important. We have to explain to the patient why reviewing so closely is important. And when the patient shows a good response, then the dose of the steroids can be hiked up, and the rest of the tapering is very similar to immune stromal keratitis. Now, let us understand this with a few case examples. So this was a 53-year-old lady who presented with 1 week history. So here we can see there is a paracentral corneal infiltrate of almost 4 into 3 millimeters, and there is a front of vascularization inferiorly. Overlying, there is a small epithelial defect. So the patient underwent scraping, and the smears were negative. And so the patient was, because of the clinical picture, because it was suspicious of HSV keratitis, the patient was started on oral acyclovir 5 times a day, along with prophylactic antibiotics. So this is also very important. You should not give it in isolation. And this is 1 week later, the image appears almost status quo. At this point, the steroids were not added because no significant response was seen. However, after 2 weeks of therapy of oral acyclovir, a significant decrease in the infiltrate size and resolution of the hypopyon was noted. So at this point, the cultures were also negative, IFA PCR was negative, and topical steroids were started. As I mentioned, they are started slowly initially. Prednisolone acetate 4 times a day was given to the patient, and on the subsequent visits within the next 2 to 3 weeks, the patient had complete resolution of the infiltrate. This is another similar patient who had a long-standing history. Here we can see there is a lot of vascularization superiorly, and the patient has a central infiltrate with hypopyon. Because the patient has thinning, or the patient also underwent TABCL, the smears were again negative, and so the patient was started with on antibiotics along with oral acyclovir 400 milligram 5 times a day. And after 2 weeks of therapy, again a significant response was noted under the TA, and so the patient culture was negative, and so the patient was started on topical steroids. With the steroid therapy, again complete resolution of the infiltrate was noted. So this was again a patient where there was a suspicion that the patient might have HSV keratitis. So here the patient had a significant hypopyon, so the patient was started on the full course of antibiotic therapy with cefazolin and ciprofloxacin hourly, along with oral acyclovir. In this case, the IFA and the PCR were positive for HSV DNA. Again, the patient was started on topical steroids after noting that the patient had a response on oral acyclovir, and with the institution of topical steroids, there was resolution of the infiltrate over 2 weeks. So before I conclude, I would just like to add a couple of points on the diagnosis of HSV. So there are several tests that are available, IFA, PCR, GIMSA stain. But the combination of IFA and PCR has the highest sensitivity and specificity, and this is what we routinely do in our practice. So if IFA comes positive, it is diagnostic of HSV because it detects the presence of the live antigen. However, this is not true for PCR because PCR can get contaminated by tears. Also, studies have shown that in normal patients, around 15% of the patients can have HSV DNA in the corneal epithelial cells. So to circumvent these problems, now people are using real-time PCR. So with this, what happens is it is a quantitative test, and the actual copies or the actual load of the infection can be understood by doing this PCR. And so we can differentiate if this is just the presence of the DNA or if it is an active infection. So to conclude, we should have a high degree of suspicion of HSV keratitis in patients who have a chronic disease, who have vascularization, footprint scars. Diagnosis with IFA and PCR can confirm the presence of HSV, but it is not necessary that this has to be positive in order to start oral acyclovir. Clinical suspicion alone is sufficient. And oral acyclovir has to be started first, and after documenting a negative culture and response with oral acyclovir, that is when we start low dose steroids, keep the patient on a close follow-up, and if the patient is responding, hike it up and taper it in a similar fashion as immune stromal keratitis. Thank you for your patient listening.
Thank you, Dr. Anahita, for summarizing such a complex scenario, because this is something that troubles us even after years of practice and seeing HSV patients. NSK is very challenging to treat because we are never sure whether it is NSK or a microbial infection that we are missing. So next we move on to HSV endothelitis, all that you need to know, to be presented by Dr. Niket Gandhi.
So very good morning all of you. At the outset, I would like to thank the scientific committee as well as Dr. Vikas for giving me an opportunity to present on this topic in the All India. So my topic today is HSV endothelitis, all that you need to know. Now again, inflammation of the corneal endothelium is something which we don't see very often, but then when we do see it, it's a very unique picture. In this case, we see that the endothelial function is disrupted, and it can cause subsequent visual changes as well. And we do see a stromal edema without any very enhanced stromal infiltrate. The three main clinical features in a very simplified and a very basic version of endothelitis would be the KPs, which we see, the corneal edema, and the iritis, which is seen in many of these cases. So the etiology is quite varied, except for HSV. The other common viral infections in these cases are VZV, CMV. It can be any medication related. It can be one of the differential diagnoses is fungal and fungal keratitis, and other cases like venom can cause this type of clinical picture. It does in few of the cases we do see that it occurs in isolation, but in many of the cases it does occur with interstitial keratitis, iritis, and trabeculitis. Now again, the immune inflammation or the immune endothelitis is due to the cellular immune attacks on the endothelial cells, and once they are in the outer membranes marked with the HSV antigens, the immune attacks are exerted by the immune cells floating in the aqueous humor, and they are the primed immune cells to which the endothelial cell membranes is attached on. So there is no direct vascular contribution for immune endothelitis. Now the stark features which we see the difference between endothelitis and the stromal keratitis is that the target of inflammation is endothelium. KPs are in a very primary and initial infection. We see that the KPs are under the area of edema only, and the non-edematous cornea is not really affected. However, in very few cases, we do see that there is intractable corneal edema, which may require further intervention. Now, in a study by Helena et al., they did study the endothelial environment in HSV, and in vivo confocal microscopy, they saw very distinctive changes like pseudoguttate and enlarged intracellular gaps, as well as infiltration of the inflammatory cells into the endothelial layer.
There's also a loss of defined cell boundaries and endothelial denudation. So there is a specific attack against these endothelial cells, and we see distinctive changes because of them. Now, coming on to the classification of HSV endothelitis, the three usual classification which we see in the textbooks are the disciform keratitis, the diffuse endothelial keratitis, and the linear endothelial keratitis. Coming on to a very unique kind of a clinical picture is the disciform endothelitis. In these cases, we do see photophobia, limbal injection, and iritis, and there is obviously a reduced visual acuity because of the presence of the location of the lesion. And again, the edema can be central or paracentral, and the haze is typically very ground glass in appearance, and the KPs again are just behind the stromal edema. And in few of the cases, due to the presence of trabeculitis, there can be elevated IOP as well. Now, treatment in these cases is exquisitely sensitive to topical corticosteroids. There is complete resolution if treated early of the edema and the KPs, and you can see in a few weeks the patient goes back to normal. There can be the resolution is without stromal scarring, and in few of the cases it can be again self-limited, but in severe cases we do find permanent edema, scarring, and the neovascularization if untreated. Now, the same study which was mentioned earlier shows the endothelial cells which were affected in cases of HSV endothelitis before the treatment, and after the treatment you can see how beautifully the endothelial cells have resolved back to normal. And this is where we come to know that treatment, if early in these cases, do result in beautiful resolution of the disease. Again, the next very unique scenario which we see is a linear endothelitis. Now you can see like any keratitis, they do present with pain, photophobia, and injection. However, clinically we see a line of KPs which are on the corneal endothelium, and they progress towards centrally from the limbus. Now again, peripheral stromal and epithelial edema between the KP is seen, and the non-involved cornea is again devoid of any KPs or edema. In a beautiful case report by Shin et al., they saw the presence of herpes simplex linear endothelitis in a post-keratoplasty patient, and we can see how the KPs are starting from the host cornea and going on to the graft, and a distinct area of KPs are seen and underlying endothelitis along with the stromal edema as well. Now, one scary type of endothelitis is something which you see in this clinical picture is diffuse endothelial keratitis. The unique feature about this is the retrocorneal plaques which are seen and the scattered KPs all over the cornea, diffuse stromal edema, and severe iritis. Now, a report by Todokoro et al., they saw similar cases where they saw deep stromal or endothelial infiltrate with feathery margins, and like any other clinician, they suspected fungal keratitis in these cases. They did their due diligence. They started the patient on antifungal medications, and they scraped the patients. And since the resolution was not seen, they went ahead and did an aqueous humor tap in these cases, and they did find the presence of HSV. And the patients were subsequently treated on oral ACVs as well as topical steroids in a very controlled manner, and you can see that in this type of clinical scenario, you do see resolutions. So disciform and diffuse endothelial keratitis do need oral ACVs and topical corticosteroids. However, in linear endothelitis, it can be stubborn at times, and even oral corticosteroids can also be required. My take-home message from this particular presentation is that early diagnosed endothelial keratitis can be treated with topical steroids with excellent outcomes and very minimal recurrences. Again, differential diagnosis of HSV endothelitis needs to be considered in cases of retrocorneal plaques. And it is important to understand that you need to do your due diligence when you are suspecting HSV endothelitis, and do rule out other scary infections like fungal keratitis in these cases. And there is a definite role of RT-PCR of aqueous humor in cases of suspicious infections. Thank you.
Thank you, Dr. Niket. So just to add 2 points here for HSV endothelitis, It is important to differentiate from immune stromal keratitis, number one. And the key to differentiation is that the edema is disproportionate to the stromal inflammation in endothelitis. And that is where you differentiate it from immune stromal keratitis. Immune stromal keratitis may have mild edema. Endothelitis will always present with disproportionately more edema as compared to the stromal inflammation. And important to differentiate because endothelitis requires oral acyclovir only, and topical acyclovir will not work in endothelitis as a prophylactic that we give in immune stromal keratitis. So oral acyclovir is a must for endothelitis patients versus immune stromal keratitis.
Just to add on to that, the very distinctive slit lamp examination in these cases is where you have a slit beam on the clinical picture and you see cellularity on the posterior stroma as compared to a frank infiltrate. And this is where you can distinctively say that this is mostly endothelitis rather than immune stromal keratitis.
So in my last presentation, what I'll be doing is that trying to summarize some of the pearls that my fellow speakers have given and try to give you the main pointers through this instruction course. Due to shortage of time, I'll be going a little faster. So as we have seen that it is a very challenging disease to treat, HSV in its various manifestations. And there are so many challenges when we come to treatment of varied presentation of HSV. So to make the diagnosis easier, when we consider epithelial keratitis, just learn to differentiate between a true dendrite from a pseudodendrite by keeping these 3 points in mind, that a pseudodendrite may not be a true ulcer. There is absence of dual staining in a pseudodendrite as compared to true dendrite of HSV, and there are no terminal knobs present in a pseudodendritic pattern. Now, look for clues to support your diagnosis when you are dealing with recurrent episodes or a patient with immune stromal keratitis. Look for history of recurrent episodes, footprint scars, and do a dilated retroillumination examination to look for ghost vessels. Now, if we look at this patient who presented on treatment for 9 months with steroids and acyclovir combination multiple times, had recurrent episodes of redness and pain, and you can see a multifocal infiltrate in this patient. We did a corneal scraping, and what we found was microsporidial spores in the stroma. And we did a therapeutic keratoplasty as indicated in this patient, taking eccentric graft to resolve everything. So just a simple scraping could have reached a diagnosis, but the patient was repeatedly being treated for HSV for the last 9 months. So don't fall for the trap of diagnostic momentum. So often we see patients who come to our clinic diagnosed case of HSV keratitis. No, there's no case which is diagnosed case of HSV keratitis when the patient has first walked into your clinic. Look at it from a very fresh eyes perspective. See everything from a very fresh perspective. Don't fall for the trap of diagnostic momentum. Whenever you are in doubt about the diagnosis, do not hesitate in doing a corneal scraping. You might not find anything, but that will not be a loss at all. HSV is a great mimicker, but the same infections which HSV mimic can in turn mimic HSV. So you have to remember that. In terms of treatment, in cases of treating epithelial keratitis, remember that ganciclovir might be slightly tolerated better and have better acceptability because it keeps the vision clear. Acyclovir, when you're giving 5 times a day topically, will keep the patient blurred for most of the day. Keep the patient's vision blurred for most of the day. So ganciclovir is a gel formulation, so therefore keeps the vision slightly better and better tolerability. When to use oral acyclovir in epithelial keratitis? Just when there is associated ocular surface issues, patient is on multiple AGMs, there is a component of neurotrophicity in the patient, and you don't want to harm the surface any further. Any role of dual therapy? Many patients come to us with oral plus topical acyclovir being given in epithelial keratitis itself. There is no evidence that simultaneous use of 2 antiviral agents will help in faster resolution, so don't go for dual therapy in these patients. Now, patients who have a longer time in healing in cases of epithelial keratitis are the ones which have a larger geographical ulcer, those who have a peripheral or limbal lesion because their inflammation is much more, and have associated stromal inflammation, underlying infiltration, and sometimes, very rarely, acyclovir resistant strains. So in geographical ulcer, the cause is usually either a delayed treatment or the patient has been given topical steroids previously, or the patient is in an immunocompromised state and therefore progressed to geographical ulcer from a epithelial keratitis. And sometimes when you see these infiltration after epithelial keratitis healing, you can add topical steroids after the epithelial lesion has healed, but keep the patient on antivirals as well. Now, this patient came to us with a presentation of decreased vision and was on steroids and antiviral combination for HSV. But when we stained the patient had an epithelial defect. And on scraping, it turned out to be pythium keratitis. Again, not falling for the trap of diagnostic momentum, do a corneal scraping whenever you are in doubt. We stopped the steroids and the patient progressed very fast. So head study we have already summarized. So just the key point, do not rush to add steroids when you are doubtful about your diagnosis, and do not rush to stop steroids when you know that it is HSV immune stromal keratitis. A slow taper is the key here. And I've already given you the regimen to follow in the clinic for effective outcomes and avoiding multiple recurrences that the patient can present with. Now, what is the duration of prophylactic therapy needed? Important factors you need to consider. This question we are asked very often because the patient doesn't want to continue on the prophylaxis. So see that when was the last recurrence? Has it been more than 6 months or 1 year since the patient has had the last recurrence? What have been the number of recurrences that have been there on prophylaxis? Is the patient one-eyed, has a bilateral disease, or a precious corneal graft that needs to be protected? In these scenarios, lifelong acyclovir may be needed. Is there any evidence of renal toxicity previously? The dose might need to be reduced or stopped completely. And remember that patient will benefit only till you are giving the prophylaxis. Beyond that period, there is no benefit of previously given acyclovir. So no clear guideline, but continue as long as possible. And if you are considering stopping, at least there should have been no recurrence for the last 6 months in the patient of steroids. So that is the important keyword here. And as we discussed previously, renal function tests ideally every 3 months, but 4 to 6 months is also fine. Then the last slide is the most important, as I emphasized before also, that the counseling of patients is the key in this scenario. You have to tell them that this is not a local infection, it's a systemic infection, it's in their body. The treatment cannot eliminate it, but only reduce the recurrent episodes. They are bound to have breakthrough episodes. They will ask you often that, why am I having this and I'm taking oral acyclovir? So you have to tell them ahead that you might have recurrent episodes, but the frequency will reduce. The need for prophylactic therapy for long-term needs to be explained to these patients, and tell them that recurrence may occur whenever, even if you are on prophylaxis. But the severity might be lesser, the frequency might be lesser. Give them the warning symptoms of recurrence so that they seek early care, and the scarring that happens is much lesser than what it would happen in a severe episode. So tell them that anytime you have pain, redness, congestion, slight decrease of vision, discomfort, come to the clinic straight away. Tell them the gravity of situation, that your vision may get affected permanently if there are repeated episodes that are happening, and that is important to understand. And tell them that they will need repeated renal function tests when they are going to be on acyclovir for long term. If we are true to our patient and honest with our patients, then they will follow our advice to the book. So that is all we have from our instruction course. And thank you everyone for being such a good audience that we didn't expect at 8 o'clock in the morning. And hopefully we were true to our, the instruction course was good enough for you to take some learning points and key points to your clinic, and maybe we will see more and more happy HSV patients rather than unhappy ones. Thank you everyone.
Thank you everyone.